A generation ago, a trip to the family doctor meant a quick phone call for an appointment on the day, a short time in the waiting room, and then a rush-free consultation. Mind you, our doctor smoked while he diagnosed your illness. But those days are over, good and bad. It's more like this now.
The cost for many patients to see their family doctor is to jump by nearly 8%. That's the highest rise in years, and there are warnings it could mean some practices shut down.
Would you pay $150 to see your GP? One Taranaki family doctor says his long-time patients are willing to pay what it costs to keep the practice open, at least for now.
The price of a doctor's visit can decide whether or not they will go.
$19.
$20, I think. It would be better if it was a bit less expensive.
Every year they increase.
How do you feel about that?
Frustrated.
1 in 3 people are waiting over 2 weeks for a GP appointment, while more than 1 in 6 wait 3 or 4 weeks or even longer. The Health Minister wants to bring in targets for primary care wait times, but doctors say that shouldn't be the only measure of good care.
But some GPs say that a key part of the problem is the 15-minute appointment, which is not long enough to complete a consult and then do all of the admin work involved.
I'm Sharon Brett-Kelly, and today on The Detail, why the tradition of a family doctor visit is crumbling and what has to change.
GPs have to have a knowledge of the full spectrum of healthcare conditions, so they're like the super specialists. In fact, the GPs probably have the biggest brains of all the doctors. They're the super specialists.
That's a pretty contentious statement from Professor Robin Gould, Dean of Bond University's Business School in Queensland. But he was at Otago University for years and his expertise is New Zealand's health system. And we'll hear more about why he thinks our universities and governments have underrated our GPs for years. But now
we are falling over because we're exhausted and there has been no real investment despite the change in complexity and volume for years.
Dr. Samantha Merton is president of the College of GPs. She also has a practice in Wellington. She's talking about the rising complexity and volume of patients and their illnesses. And we all know what it's like to be the patient, but what about the doctor? What sort of prep goes into that 15-minute visit?
If it's someone I don't know at all, I might have a quick look through their notes and just check on what has gone on for them before. So I've got a little bit of knowledge about them and who they are. If it's someone I do know, I may be looking to see what we were doing last time and what the next steps are and that we had planned. So I know what they're coming in for that day. But a lot of the time, what we expect that someone's coming in for is completely different from what they actually are turning up for. So it's not predictable at all.
These are patients that might be on your register. These are people that, you know, you have history with. But what about if you're seeing a new patient?
So if I'm seeing a new patient, then in my practice, my nurse may have seen them beforehand and gone through a few of the basic details about allergies, medications they're on. For our women, we check what contraception they're using if they are. We check what tests they've had done, and we make sure that we've got all their details of their screening history as well, and then their medications are loaded up. So when you've got someone new, you spend a bit of time getting to know each other. So you have to, they've got to trust you that you are going to do a good job, and you've got to know them so you can do a good job.
How often would you stick to that 15-minute consult?
For me personally, ask my patients, never. So yeah, if it's 15 minutes, it's completely surprising. I feel quite good when I get to sort of 10:30 in the morning and I've only got one more person to go, and they were meant to be seen at 10:15. So that's an achievement on my part.
If you can't stick to the 15 minutes, does that mean that you don't get paid as much?
So yeah, if the funding's based on a 15-minute consultation, and that was sort of an arbitrary decision made 25 years ago, and it was based on some evidence at the time, but the complexity of health conditions has increased so much and the shortage of GPs have increased, so that now people come in with a list of things because they don't come in very often, or they do come in regularly, but they have still got a whole lot of conditions that you're dealing with. So financially, if it goes over 15 minutes, the capitation fund is only for one lot of 15 minutes and maybe 3 times a year. So as soon as you've done half an hour, your next consultation, if it's another half an hour, you've only got 15 minutes funded by the government. And any other consultation over the rest of the year, unless they come 12 times, you don't have any extra funding for. And so they're just paying over the counter. Charging patients for half an hour when they've booked 15 minutes is actually hard to do because we know that people are short of fund and it's difficult. And so sometimes I'll say, look, that's taken us a lot longer and we'll need to charge you for half an hour. And they'll say, okay. But I do that at my discretion. If I did it all the time to everybody, maybe that would be the thing to do. But actually, for some people, paying a double fee is quite hard.
From $19 to $90, the price of a trip to the doctors varies throughout the motu. And over the last 2 years, data shows the cost of seeing a GP has jumped 23% on average.
The average is around 60 to 65. The thing that's really interesting is you wouldn't go to your hairdresser and not pay, but because health is such a personal thing, I think because it is sometimes out of your control what goes on with your health, and because the people who are really unwell are often the people who don't have jobs or don't have a huge income, and so then charging them an enormous amount, so $120, feels hard.
Do you ever avoid going to the doctors because it is pricey?
Yes, sometimes that if they not enough money, I not go, but I need to go to see the doctor.
There have been a lot of times I've put off going to the doctors, to be honest, because I'm like, I just don't have the money for this right now, you know. I'm not rich, but I've got family who pay like $50 just to go to the doctor, and they're like, they haven't gone for a couple of years.
How would you feel if things were to go up?
I just wouldn't go. I'd be like, screw my health, I can't do it.
How do you get around this? Because clearly it's not working, and we're hearing that some GP practices, they're not viable anymore.
We've continued to stretch as much as we can. So we do as much as we can in the 15 minutes. We work through our morning tea breaks. We work through our lunch breaks. We do extra on top of it. We work around having other team members in our practices to take some of the low-level tasks away from us so that we can concentrate on the complex stuff. But then as soon as you employ another person, that's another funding revenue that you've got to find, and they may not be as broadly scoped or able to do as the vast array that we do because of our extensive training. So it has got really hard. I think trying to make ends meet has been much more difficult. The ability to increase our fee to the patient has always been constrained. There was a little bit of a uptick in that last year when they said with the average is 65, so as long as you aren't too far over that, then we won't be reviewing your fees. I don't know if you're aware that we get capitation funding, which comes from the government and is set at a certain level, but we also have our fees ourselves constrained, so we don't end up charging too much money. And for the practices who are like mine and some of the very low-cost access practices over the years, if you started with a low fee in 2001 when your capitation came in, that incremental change of 2% or 3% on that fee is completely different from the incremental change of 2 or 3% on a $50 fee. So if you started low, your increase has not gone up in the same way that someone who started on a reasonable fee. And some of our practices, like the very low cost access practices, their fees have never changed. And the complexity has continued to grow. And also in a high needs population, that complexity is way more exponential growth has gone on. Yeah.
And what's the consequence of that?
Well, we work every hour known to man. I think if you're trying to fund your business, you fund all the business itself and all your staff, and you're the last cab off the rank as far as your salaries go. A lot of us, I haven't had a salary change for 5 years in my practice, and I'm the most senior person and supervise everyone else. I don't think there'd be many businesses where the senior professionals in the role would be taking a pay cut to make sure that they kept the doors open. And I think there would be many senior professionals who would expect an incremental change in their salaries over 5, 10 or 15 years. And you could probably guarantee that most of our GPs, especially the ones who are working in high need practices, haven't had a significant change at all over the last 10 or 15 years.
Is that why we are seeing increases in things like if you want to renew your prescription, it's now $30. Seeing the nurse, those charges have increased?
Yes, I think what has gone on is that it's still professional time when you think about it. A prescription in our practice, and I'm sure there's many who do the same thing across the country, and there'll be some who don't, but for us, we would look at the prescription, and I do it because I'm responsible for what gets prescribed. And even if you used a nurse, then they can do a certain amount, but you're the one whose name is on the end of the prescription. So we look through the notes, make sure that all the checks and balances have been done, that they're on the right drugs, that should be taking it, when were they last reviewed, and do they need to come in or have some blood tests, or are there other things that we should be doing and catching up with them for preventative health concerns. And so it's not, the $30 is not just I've clicked a button and said yes. It is actually a review process as well. You're actually asking someone who's a professional to make sure that that piece of paper is the right stuff for you, is being monitored, and has keeping an eye on your other health parameters as well. Yeah.
Because some people might say, well, I've just made a phone call to ask for a prescription renewal. Why should I pay $20 or $30 for that? But you're saying it's not just like printing a piece of paper out and putting a signature. You're saying that it still has to go to a GP to be checked over.
It does, because we're responsible. And there's lots of drugs that are really complex and have monitoring requirements. And sometimes, like some people are on medications that another specialist might have prescribed for them. So someone in the hospital, and there's monitoring that needs to happen. And it's harder for hospital doctors to check on those blood tests regularly. So they come into our inbox and we might be going, well, okay, the things are starting to change. And so what do we do now?
Speaking of email inboxes, just listen to Dr. Carl Cole talking to RNZ's First Up.
This is the kind of inbox we have with that many messages coming in, pages and pages of them. Yeah, it's hundreds.
So it is keeping an eye on change, but then when they come in a year and get reviewed, there's still a whole lot of other things that you want to check on that are preventative medicine as well, which is really keeps people healthy. And that's another part of our job.
7, 28, 29, 30. Need me to jump in? I'm all good. Draw up adrenaline and amiodarone.
They don't have the glamour or drama of a hospital ED, but general practitioners are the heart of primary care. Primary care also includes nurses, occupational health workers and the public health professionals working to keep people out of hospital. Robin Gould says it's no exaggeration to say the way we educate, fund and retain our GPs is in crisis. And a report out yesterday backs him up. Fixing it won't be easy, but Robin says the government should start by doubling the investment in primary care to 10% of the whole healthcare budget.
Especially if you want to keep people out of hospital and keep them well managed in the community, and especially if you want to try and grow the workforce and make it a positive and productive place to work. There's some negativity, and there has been for quite some time around this area. It's very, very hard work. The GPs will probably tell you that their work is much more demanding than your average hospital specialist. I mean, this is quite a contentious statement, but you will hear this if you go to conferences, and they'll say that that's because they see patients pretty much every day of the week. All day they're seeing patients, seeing them and treating them, referring them, prescribing medicines and so forth. And so they're under a lot of demand that the hospital specialists are not necessarily so. They're under a different kind of demand, of course. That's probably not helping in terms of the perception out there around whether this is a great place to go and work. Our medical schools also have probably not done as well as they could have in this regard. GPs have to have a knowledge of the full spectrum of healthcare conditions. So they're like the super specialists. In fact, the GPs probably have the biggest brains of all the doctors. They're the super specialists. Philosophically, There is an argument that general practice should be promoted within medical schools as actually the super specialty. So if you really want to aspire to the highest status in medicine, you should be a GP. At the moment, it's often seen as kind of the lower level work, that the super status is, being a cardiac surgeon, for example. That's a really important profession. But if all of our doctors are aspiring to specialty, then you're actually undermining the very idea of a strong primary care system. So we face this challenge in New Zealand as well, and I would like to think it's something that we could grapple with at the highest policy levels as to how we start to shift that thinking.
One of the issues that has come up in the last few days, as you said, is the 15-minute visit. What would be a more realistic model? 20 minutes or 25 minutes?
Probably to have an arrangement where the GPs are salaried so that they're not contingent on this fee for service and about giving them a bill for 15 minutes or for 30 minutes. You probably want them on pay parity with hospital specialists, and just to roll that out across the general practice sector. And if that were the case, then the GPs would be able to focus much more on who the population is, who are the patients that really need to be seen, which ones need an hour, which ones maybe only need 15 or even 10 minutes, which ones you can deal with through a telehealth. How do I work more with the public health professionals? All of these concepts we have had in policy documents and talked about for a very long time in New Zealand. And I think the funding model is what has been the key barrier to achieving those sorts of goals.
Yesterday, the think tank, the New Zealand Initiative, put out a report saying primary healthcare is at a critical juncture. It spells out its many problems, including funding gaps, workforce attrition, and fragmented IT systems, including a lack of data sharing that would help doctors diagnose and refer patients.
We have a rather unfortunate legacy of multiple parallel IT systems that don't necessarily talk to one another, just so far from ideal. I mean, at the moment, a GP can't sit with you and say, you need to see a specialist. Let's find you a time right now and book you in. You just cannot do that. You can't see the hospital specialist books. It doesn't work that way. That's quite complex as well, because hospital specialists, 60% of them have a private practice. This is a grey area. So to try and say, what days are you going to run clinics on? Let's open up the books and link them with primary care so that people can book in and see it on an app themselves when their appointment is. This is quite challenging sort of culturally to try and solve that problem. We put out a report about this time last year actually on the increasing rate of risk of being rejected when you're referred by a GP through to a specialist for an appointment. That had gone up by 5% per annum over a 5-year period. So it's a bit like, you'd be thrilled if your risk of, or your chance of winning lotto was going up by 5% per annum. But this is the risk of not being seen by a specialist, despite a GP finding that you've got a clinical need to be referred through to be seen. We were talking about going up from 11 to about 14% of patients being rejected from a specialist appointment. We also looked at the impact on the GPs. Many of them said that they were managing patients that were outside of their scope of practice, that they felt it was extremely risky. They were dealing with drugs that they weren't qualified to be prescribing. So, we need more research onto these kinds of topics.
It's been hard work getting things changed. When you think about should you value general practice or general practitioners more, it's a historic quirk, but our trainees have to pay for their training in their second and third year, whereas every trainee who is a specialist in the hospital gets their training funded. I've been working for 9 months on trying to get this shifted, and it has been really hard to get agreement. I don't know whether the impasse is that we think we could use other people rather than general practitioners, or whether the impasse is, well, you get public money and private money, so you should be able to afford this yourself. We do have a public-private partnership, but in our GP training program, our practices pay for the salaries for years 2 and 3. Our practices support our registrars in their second and third year, and our registrars pay for their own training. In every other service where you're developing people, the trainees aren't paying the high cost of that training, and they'd have supervisors who are supported to supervise, and it's not coming out of the pocket of the business owner. as the supervisor as well to make that work. And I think we have invested an enormous amount from the practice perspective into GP training, and we want to shift that so that actually we value the development of our GPs and we value our registrars who are working and we keep them, and we also value the people who are doing the supervision.
If things don't change, what's the future?
There needs to be multiple changes because this has been an incremental devolution of the service over many, many years and in many parts. So our support for nursing, like our nurses pay parity, we need to change that so that nurses are paid at the same rate as they are in the hospital so that we can keep them in primary care. We need our GP seniors being able to actually afford to pay themselves a salary that their colleagues would be getting, so that we're not sort of putting all our money into our business and not being able to fund ourselves. So that means capitation needs to change. I think we need to recognise that there is a broader team, but the fact a broader team does cost money, and so you can't develop a broader team based on the same fund. So if you do want a broader team, then it needs to be funded in different ways. So there are multiple areas that need to be resourced. And if you think that we only spend 5% on general practice and the rest of the globe spends close to 10%, then that 10%, that extra 5% has many places it could go and would be very effective. So we do need to work our way through shifting the dial from 90% of the fund going into hospitals who do 10% of the work and make it 10% of the fund going into community care.
Roughly, GPs, of your experience with your amount of training, because presumably you did several years of training, what would be the annual salary?
That's a complex question. The average salary at the moment, based on our 2022 workforce survey, we haven't got the 2024 one finalised yet, was 223,000 was the average across, and that didn't change between the age of 35 and 65. So that's across the board. I'm glad you made a shocked noise then. That means that we're probably on about $100 an hour, which your electrician's probably on. That's me being facetious, but we aren't on enormous salaries compared to our colleagues in the hospital. If you're in a hospital, you get all your CME paid for, so there's another bonus for that. If you work hours outside of your hours, you get time and a half or whatever it is, you get external hours. We have to do that. We have to work 40 hours of seeing patients, and then we have another probably 20 hours or at least 15 hours of doing other paperwork on top of that. So we're actually working 55 hours a week on that salary.
God, it's almost as bad as journalism. And I'm being facetious there.
I was talking to Mike Hoskins and I said, it's like saying that the only work you do is when you're on air. And he went like, shit, no. So yeah, we don't only work when we're in front of a patient. That's the point.
That's it for today. Thanks to Robin Gould and Samantha Merton. The Detail is a newsroom production supported by RNZ and New Zealand On Air. This episode was engineered by Mark Chesterman and produced by Alexia Russell. I'm Sharon Brett Kelly. Ka kite.